So we're starting. Good afternoon, everyone. Welcome back to our second lecture under Department of Medical Oncology. Today we have a topic taken by Dr. Raju Titus Chacko. Sir is a professor in our Department of Medical Oncology, CMC. Sir has completed his undergraduate and postgraduate studies in Christian Medical College, Vellore, and had his medical oncology training done in Royal Adelaide Hospital, South East Australia. He started the medical oncology department at CMC Vellore in the year 2000. The department is now well known for its teaching in surveys and research. Sir has been actively involved in research and has been principal investigator in several clinical trials. He has several publications to his credit, and also Sir is a member of several professional organizations, both national and international. But today, sir's topic will be approach to stomach malignancy. This is basically meant for a target population will be our medicine PG students, but it's open to anyone and everyone. Please feel free to ask questions through the session, or maybe you can put down our chat box if any doubts anytime. This lecture will soon be uploaded on our Department of Medicine YouTube website. Thanks again, sir, for agreeing to take this lecture for us. I know you are very busy, but then we are very grateful, and we've been honored also to have a lecture taken by you, sir. Thank you, sir, and over to you, sir.
Thank you, Anju. I'll share my slides. Okay. Are the slides visible?
Yes, sir. It's visible.
Okay. Thank you. So my brief today is to talk a bit about gastric cancer. So what I decided I will do is, to take you through a kind of a broad vista of gastric cancers and how you might approach them. I won't go into great detail because that would be, a bit esoteric for this group. But I think it's worthwhile for all of us to understand this disease to a certain extent. And I will try my best to help you understand that. Okay, so gastric cancer is not a modern disease by any stretch of imagination. It's been, there have been hieroglyphic depictions of it, in ancient Egypt as far back as 3000 BC. And we know that even in the 16th and 17th century, there have been statistical mentions of gastric cancer as to the incidence of gastric cancer in different parts of the world, especially in places like Italy. If you look at the epidemiology per se, you can see that, if you look at all the GI malignancies per se, you can see that they account for almost 26% of the global cancer incidence, 1/4 of the global cancer. But they also, are the reason for 1/3 of the death. And if, so there are supposed to be about 4.8 million new cases of GI cancers and the 3.4 million related deaths worldwide. Now, gastric cancer accounts for about 6% of all the cancers, and about 8% of all the deaths of cancers is related to gastric cancer alone. Interestingly, in 2016, there was a Lancet publication doing a verbal autopsy on patients of all the mortality related to cancers in India. So they looked at various places and they did this verbal autopsy. And gastric cancer was the #2 cause of death in Indians with any malignancy. So there's an estimated 1 million new cases and about 0.77 million deaths. This is all worldwide. Now, interestingly, in India is not a country with a lot of gastric cancer as compared to many of the other countries. You can see here that we are like in the South Central Asia, right in the middle of this chart, and you can see that among men, the age standardized incidence per 100,000 is about 7.4, and in women, it's about 3.7, about half of that. Interestingly, you see men all over the world tend to have more gastric cancer than women. Maybe something to do with the hormones, as we will see later. Also, if you look at it, uh, if you look at worldwide trends, you can see that stomach cancer seems to be kind of decreasing in many parts of the world, and in other parts of the world, it's kind of remains stable. Um, Maybe it's because we are understanding that there are some foods, for example, that may not be um, that may be the cause of these, and we're avoiding those foods, and or maybe we're detecting it early, whatever. The prevalence is certainly reducing in time. The other trend that we can see is, a change in where these cancers occur. Earlier on, most of these cancers were in the distal stomach. And slowly, we are seeing an increased prevalence of cancers more proximately in the gastroesophageal junction and in the proximal stomach. That's another trend that we're seeing, and that trend can be seen in CMC as well. So let's talk a little bit about precursor lesions. So there are, classically two types of lesions described pathologically. There's the intestinal type cancer, and this is like kind of discrete lesions, more like the cancers that we see in the colon. And this is thought to be related to atrophic gastritis, intestinal metaplasia, and dysplasia, and is seen usually as discrete lesions in the stomach, and they tend to be more can be seen anywhere in the stomach, but they tend to be more distant. Then there's the diffuse type, infiltrating type of tumors, and these can, you know, um, infiltrate, and they can just form a sheet without any ulceration. In fact, if you just look at it on the surface, you may not see anything new on an endoscopy, like no ulceration or anything may be seen. And you may need to do a biopsy, going through the mucosa to actually find these malignancies. And these malignancies are, tend to produce the Linitis plastica type of cancers that we have previously been previously been taught about. Like I said, the trends seem to be more towards having proximal adenocarcinomas compared to the previously more distal cancers. And one of the reasons why this is probably because of the increasing obesity in the world population, and perhaps the use of more PPIs as well, the proton pump inhibitors, producing more kind of refluxes and also changing the acid milieu of the stomach. There are several environmental risk factors that have been described. Helicobacter pylori is the um, what we all learned when we were students. Diet, there seems to be an increased uh, incidence of this malignancy in places where they use salt and salt preserved foods. Like, for example, in the colder parts of the world where they have to freeze their food, and they often, kind of preserve it in salt. Nitrous compounds are well known to be associated with malignancies of the stomach. Low folate levels are also supposed to be associated with uh, malignancies. Obesity, smoking, some occupational exposure of some compounds are shown to have an increase. Epstein-Barr virus has been associated. People who come from a low socioeconomic status for some reason tend to have more gastric cancers. Now, one doesn't know the reason for this, but this is an association that has been shown. Previous gastric surgery. If you've had a previous gastric surgery, your risk of uh, gastric ulcer and malignancies related to that are higher. If you've had abdominal radiation because of some other disease, like, for example, if you had um, a lymphoma in the abdomen and you had radiation for that, you have a much higher risk of having gastric cancer. There are possible protective factors: fruits, vegetables, fiber, non-steroidal anti-inflammatory drugs are said to be, uh, protective. Also, like I said, for some reason, the incidence of these malignancies in men seems to be much more than that in women. And it is thought that maybe the reproductive hormones have a protective role. There are some host-related factors which may lead to uh, malignancies. Familial disposition. There's a hereditary diffuse gastric cancer, which is hereditary. There's the gastric adenocarcinoma and the proximal polyposis syndrome, which is seen. There's the familial intestinal type of gastric cancer. And there are several other hereditary gastric syndromes that have been recorded and reported. Several genetic polymorphisms are noted to be associated with gastric cancer. Certain blood groups, for example, if you were O positive, then you seem to have an increased incidence of gastric ulcers and cancers in that group of people. Why that is, we don't know. Hypertrophic gastropathy and immunodeficiency syndromes are also associated with increased malignancy. Gastric ulcers, pernicious anemia is another thing that we all know about. Okay, then how does one, pick up this disease? Worldwide, if you look at gastric cancer, it's often picked up, even in the more advanced countries, it is often picked up at a very late stage. And today, we actually have screening in areas of very high incidence to try and pick up earlier lesions. And this is a practice in countries like Korea and Japan, where the incidence of gastric cancer is high. But how do you do this? There's endoscopy, which is perhaps the best thing. You see a lesion, you biopsy it, you know what exactly is happening. Contrast radiography with, say, barium or something can also pick it up. There are other tests that are also investigational, not really used commonly, but it's worth mentioning here. Serum pepsinogen, serum trefoil factor 3, microRNAs. There are some specific microRNAs that we can actually measure in the blood and can be used as a screening tool for gastric cancers. And there are, multi-analyte blood tests that can be done using multiple factors, again, as screening tests. But none of these have, very high specificities or sensitivities to be used regularly. What are some of the clinical features that are there? On the left, on my slide, you can see a study that was done in the US, which is reported in the Annals of Surgery 1993, which shows that the most common symptom that most people presented with was weight loss. And that's no surprise, given the fact that the stomach is the main place where, any food that you take goes in. Abdominal pain was, seen in about half the number of people. Nausea, dysphagia, melena, early satiety, and an ulcer type pain are the other common symptoms that are seen. Like I said, most patients, when they come to hospital, they are very symptomatic and have mostly incurable and advanced disease, even a diagnosis. Anemia is, a common finding at that time. And many patients have distant metastasis at presentation. Women have Krukenberg tumors. Men have peritoneal spread and ascites. And sometimes we can see paraneoplastic manifestations as well. Some of the paraneoplastic manifestations that we can see are this diffuse seborrheic keratosis, which is called the sign of lesser Trillat, acanthosis nigricans. Sometimes you can see a microangiopathic hemolytic anemia, membranous nephropathy, and sometimes a hypercoagulable state is also seen with, even superficial venous thrombosis like the Trousseau syndrome. But a lot of these patients also, present with pulmonary embolisms and deep vein thrombosis as well. How does one diagnose gastric cancer? Now, the most common way that one makes a diagnosis is by an endoscopy, where you look at the esophagus and stomach, and a biopsy that is taken from these. This will be a confirmatory test for a malignancy in the stomach. You also need a CT scan to see the extent of the disease. And on the CT scan, depending on the distension of the abdomen of the stomach wall, one might, also see quite a thick gastric mucosa, and we can sometimes see the lesion actually going through the mucosa and outside the stomach wall. We can see the nodes involved there. And endoscopic ultrasound is another way to, especially when you want to make a diagnosis of very early gastric cancer. The FDG PET is used sometimes in, looking at lesions, especially when we think that we have a very early gastric cancer and we are going in for, say, a surgery like a gastrectomy, and you want to make sure that this patient doesn't have any kind of occult metastasis. Sometimes we do an FDG PET. Peritoneal disease is not well seen on our conventional imaging like a CT scan. And before we, embark on doing a surgery like a gastrectomy, often the surgeon goes in with a laparoscope to look at the peritoneum and to confirm that the disease is surgically treatable. So here is a cartoon with the TNM classification of stomach cancers. You can see a T1 lesion, which is a lesion which has just gone through the lining of the stomach and into the connective tissue. A T2 lesion is a lesion which has gone into the thick inner muscle of the stomach. A T3 lesion has gone through the outer lining, but has not gone into any of the other organs outside of the stomach. And the T4 lesion is one that has gone into the adjoining organs like the pancreas, that is there just below the stomach. N0 is a cancer which doesn't have any nodes. And this is mostly kind of an operative kind of staging, because you can, the surgeon takes out all the perigastric nodes and many of the nodes around which are enlarged. And depending on the number of nodes that are involved, you can have an N1, N2, or N3 disease. And of course, the metastasis, if there is a metastasis, it's called M1 disease. And this is the stage grouping, as you can see. So just to this thing, any lesion which is up to T2, that means it's gone through the muscle layer, but where there's no nodes and no metastasis is called stage 1 disease. Any disease which is, um, up to stage 4 without nodes, or a stage 1, stage T1, T2 with nodes, but without any metastasis is called stage 2 disease. And stage 3 is any tumor which is T3 or more and has got, nodes there. Why do we stage these patients? We stage them because these have got prognostic significance. So irrespective of what treatment we give them, and most of the treatment for these patients is by surgery, you can see that depending on increasing stage, you have an increasing death or mortality and a poorer survival. Okay, so stage 1A is the top line there, while a stage 3C is the one right at the bottom. And stage 4, of course, has got a really dismal prognosis. Now, if you look at the guidelines for therapy, I want you to look at this diagram very carefully because it's the NCCN guidelines, which is the latest there. You can see that if a patient is operable, the best thing to do for these patients is to do a surgery. And so sometimes, you can get away by doing an endoscopic resection of the tumor when the tumor is really small, like a T1 lesion or a in situ carcinoma. One can get away by doing an endoscopic resection, like a submucous resection of the tumor, and then just have endoscopic surveillance, right, like a seen at the top of the chart here. Now, otherwise, any patient who's medically fit, surgery is the treatment of choice. Patients who have higher than a T1A lesion without any metastasis and is medically fit, the best treatment for him to have is an operation. Now, depending on where the tumor is situated, this may be a partial gastrectomy, especially if the tumor is distal, or it may be a total gastrectomy if the tumor is more proximal. Now, if the tumor is, a very large tumor or coming out of the stomach, like for example, if there are nodes positive, we now know that the addition of some preoperative chemotherapy or sometimes some preoperative chemo radiation can actually improve the survival of these patients. And there have been a large number of studies where this has been done in the past, and it is a practice around the world to do this. And we'll talk a little bit about that as we go on. Now, there are a lot of patients, for example, who are, not fit, or, the tumor just can't be taken out. In those patients, we may use the same techniques of giving chemotherapy or chemoradiotherapy to try and downsize these tumors to make them surgically resectable at a later stage. And there are a whole lot of patients who are, got metastatic disease where an operation is not going to benefit them in any way, or they're just not fit for any kind of surgery because of poor other comorbidities. They will go in for just having palliative management and best supportive care. As I already mentioned, resection offers the best chance of long-term survival for localized gastric cancers. Therefore, accurate assessment and staging of the cancers is very important. In general, tumors that are more proximal and involving the gastroesophageal junction tend to be much more aggressive, and stage for stage tend to have a poorer survival than those of distal malignancies. If you have the Lionetus plastica type of tumor, these generally tend to have a very poor prognosis, and many surgeons around the world will even kind of say that if you've got Lionetus plastica, it may not be worth operating because the benefit of that type of treatment may not actually be there. This is a cartoon which shows the what we call a total gastrectomy, and you can see that the incision is made around the gastroesophageal junction and at the distal stomach there as it enters the duodenum, and then your jejunum is pulled up, and there's an esophageal-jejunal anastomosis that is made. This is the picture of a total gastrectomy, and of course the duodenal stump is then closed off. And this is a partial gastrectomy. Partial gastrectomy can be of various types. You can, have various anastomoses as well, but basically you leave the proximal part of the stomach intact. Now, I'll come to what we do in medical oncology most. So basically, what are we trying to do? So surgery has, come to the extent where they've refined the techniques in such a way that there doesn't seem to be much more that they can achieve by their techniques. So how do we improve the survival of these patients? We want to increase their ability to take off the tumor. We want to reduce the rate of local and distant recurrences. We want to avoid the resection in patients with very highly aggressive disease who will not benefit from resection. So these are some of the advantages of giving some adjuvant and neoadjuvant therapy. So basically, adjuvant or neoadjuvant therapy kind of selects out patients who might likely do better with your operation. It also improves survival. In general, it's much more difficult to give the chemotherapy immediately post-operative. Lots of patients, after their operation, they're not able to tolerate chemotherapy as well as if it is given, before the operation. And so, people have tended to use the chemotherapy upfront before operation, which is called neoadjuvant, or around the surgery, which is now called perioperative. And perioperative therapy is what now most people use around the world. A meta-analysis of pre-op chemotherapy versus surgery alone showed that there was a significant benefit in terms of both overall survival odds of 1.32 and a progression-free survival of 1.85 in favor of the neoadjuvant chemotherapy group. There was also very significantly, more complete tumor resections following this kind of, giving pre-operative kind of chemotherapy. And this kind of pre-operative chemotherapy did not worsen any of the operative complications, and there was no increase in terms of perioperative mortality just because we gave this chemotherapy. And when compared to, patients who just had surgery alone, there were no, terrible grade 3 or 4 adverse events in this group, at least as far as this meta-analysis goes. There are various options across the globe as to which chemotherapy medicines are actually used. In Britain, for example, people use the ECF or the ECX regimen, which is, 3 cytotoxic drugs: epirubicin, cisplatin, 5-FU, or epirubicin, cisplatin, and capecitabine. And this was shown in the MAGIC study, what they call the MAGIC study by Dr. Cunningham et al. In the UK, and in the Real 2 study as well, where ECX was used instead of ECF. More recently, a regimen which uses 5-FU, leucovorin, oxaliplatin, and docetaxel, called the FLOT regimen, has been used in a perioperative kind of way, showing that compared to the previous ECF regimens, this regimen seems to be better tolerated and possibly has a better effect on the tumor in terms of downsizing it. Now, in many patients who've got gastric cancer and who come in with advanced disease, toxicity of the chemotherapy is a major concern. And instead of giving, 3 drugs, many of our patients just receive doublets of oxaliplatin and 5-FU, or irinotecan and 5-FU, what is commonly called FOLFOX or 450, and this may be more appropriate in these patients. Then, once we've given them the chemotherapy, they all go have their operation, and 4 to 6 weeks after their operation, they come back to us for further treatment. We often give them more chemotherapy depending on the stage at the surgery, what we call the surgical staging of the disease. Now, someone who's had a gastrectomy, they may, be seen by an oncologist, and they may be seen by, a physician somewhere or the other. Now, it is very important in the post-gastrectomy state to be looked after carefully. Nutrition, for example, is a very important thing. Now, you must remember that, so once the stomach is the big bag in the abdomen, and that's where all the food that we eat goes in. When you take off the bag, the amount of food that you can eat is considerably reduced. So it's just one big tube. For example, if you do a total gastrectomy, your food goes straight into your jejunum. Okay, and so the amount of food that can actually be kept in the jejunum is a small amount. So if you put in more, you'll just regurgitate all that out. So the patient has to be told to take multiple very small feeds, but he needs to have enough calories and enough nutrition to be able to manage and to change from the cachectic stage that he is in to become more anabolic. So nutrition becomes very important. The other thing that is seen in these gastrectomy patients is vitamin B12 and iron deficiency, and from a physiology why that should be. It's also important to look at the comorbidities of these patients. For example, somebody who's had a gastrectomy and who's diabetic and who's on certain drugs, for example, their risk of problems like hypoglycemia are quite large. And the physician needs to keep an eye on these so that a patient doesn't suffer from hypoglycemic attacks because of the amount of food that he takes is less. And of course, it's important to keep patients under surveillance because the risk of recurrence of this disease is very high. So what happens if these patients recur? And this is not an uncommon finding. It is something that one does see in a large number of these patients. So if the lesion on recurrence is resectable and medically operable, then the operation, a reoperation is often considered, but often not possible because by the time they develop recurrence, these tumors are usually metastatic to other parts of the body, and then just the locoregional therapy may not really be beneficial. And so most of them kind of end up with palliative treatments or palliative managements, as we can see. Now, what happens when the patient comes to us, de novo with very, very advanced disease? okay, or has a patient or who has a locally advanced disease, which the surgeon says, I can't uh, touch this patient. What do we do? Now there are a number of options that are suggested, and this NCCN guideline actually suggests that uh, when we do a biopsy, there are two, three things that we should do. And they suggest that we do a HER2 new testing on it, because there are some gastric cancers, about 2 to 3% of gastric cancers, which may be HER2 new overexpressing. They also suggest that we do a PDL1 expression. They also say that we should do an MSI to look to see whether these are MSI high tumors or not. Now, in the event that the patient can be treated with the local chemoradiation or with some systemic therapy, that's what we would do. But should the patient have one of these markers which suggests that specific treatments can be given, we could always consider giving them specific treatments, and I will come to that in a minute. Now, patients sometimes cannot receive these specific treatments for one reason or the other, and those sort of patients are referred for best supportive care or palliative care alone. What are some of the palliative systemic therapies that one might be able to consider? In the first line setting, that means if the patient has never had any treatment before, the possibilities are giving them, a doublet like Folfox or Folfiri, as I had noted, even in the preoperative kind of setting. In patients who progress with that disease, often we give them weekly paclitaxel with a VEGF vascular endothelial growth factor receptor inhibitor, which is a drug called ramucirumab, and that's been shown to improve survivals by a few months. If the patient has a tumor which is HER2 new overexpressing, or which stains on an immunohistochemistry as a 3+ tumor, trastuzumab, which is an anti-HER2 new therapy, has been used uh, with good survival benefits in patients. And we have a number of patients who have, taken this anti-HER2 new therapy for 2 to 3 years, even with very, very advanced tumors. And there is now emerging information on a antibody, a trastuzumab, uh, combination, which is called the trastuzumab deruxtecan, which has been now being used in patients who have progressed on trastuzumab alone. And this is showing a further improvement in survival by a few months. Now, as I mentioned, if the tumor is MSI high, or if there is a huge high tumor mutation burden, or if the PDL1 is high, these patients can be offered checkpoint inhibitors like nivolumab or pembrolizumab. And these patients too might have a benefit of several months. Now, interestingly, these checkpoint inhibitors, there's about 1/3 of the patients who respond to the checkpoint. Not everybody responds to the checkpoint inhibitors, even in spite of very high uh, MSIs or PDL1s. But in the patients who respond to the checkpoint inhibitors, there's about 30% of them that actually have very long progression-free survivals. The tumors are never cured, but they have very long survivals with, disease control, which sometimes goes for many months, many years. And now there are a lot of new, um, typically these patients have their tumors sent for next generation sequences, and these have thrown up um, several driver mutations in these tumors. One of them is this NTRK gene fusion. And there are now specific drugs which we may use in those patients. Now, I must say that these fusions are quite rare in gastric cancer and may be seen in less than 1% of these tumors. But in those who can afford to have their tumors sequenced, and in whom gene fusion like this can be found, it is quite possible to treat them with drugs, which might again cause quite dramatic changes in their tumors. And lastly, one mustn't forget that although we have all these tools in our kit to try and treat these tumors, we mustn't forget that the patient is the one who is in front of us, and he comes to us with certain symptoms. He may be having pain, he may be having bowel obstruction, he may be bleeding, he may be cachexic, and to add to all of this, he has a social problem. And it is important for us to address these problems as we, continue to try and, reduce the tumor burden or improve other symptoms that he might have. So one of the things that is, commonly seen in our OPD is when we see somebody who comes and says, I have pain, is to say, okay, take this now, your pain will be all right, you go away. But one must understand that, for example, there's no, meter or no measure of pain except from what the patient tells us. So if the patient is telling you that he has pain, he has got pain, and one must listen to him and make sure that we try and control that pain in whichever way possible. Often, these symptoms of pain and bleeding can only be done with can only be treated with a surgical resection, and these patients must be treated to an early surgery to help them out with that. So that's all that I have for you. Thank you very much for a patient hearing. I'll be very happy to answer any questions that you might have.
Thanks a lot, sir, for that very simplified, detailed lecture on approach to stomach malignancy. Any questions or doubts? Please feel free to type in the chat box. Sir?
Tell me.
So for this locally not advanced, as in terms of stage 1, stage 2, when we say that we offer neoadjuvant chemo plus a surgery for an arterial resection, is there a role for HER2 expressions and other PD-L1 markers to be looked into early stages of malignancy?
Yeah, usually we don't use those drugs in that kind of a setup. So, HER2 new and those kind of drugs are not used in those early gastric cancers. But in patients who have advanced gastric cancers, these drugs are quite commonly used.
So are we expecting like a totally curative or a progression-free survival that we look into for an early stages?
In advanced diseases, we are trying to, we're trying to get a progression-free survival. We're trying to reduce this guy's symptoms. We're trying to increase his overall survival by a little bit.
Early?
Gastric cancer being a very, very, it causes a lot of symptoms, right? So it has a great impact on a patient's quality of life. So if you can help that is what we're trying to do by, treating advanced disease. In early gastric cancers, the aim is cure. Okay, so we are trying to, reduce your disease. We're trying to reduce systemic metastasis. And if there is any metastasis, we're trying to take care of that. And we're trying to increase the operability, which therefore leads to better cure rates.
Thank you, sir. Any further questions? This lecture will soon be uploaded on our Department of Medicine YouTube website. Thank you, sir. Thanks again for this lecture from you. I think we'll wind up, sir, for today.
Thank you, Anju. Thank you, everyone.
Thank you, sir.